Taking time for your health. The African American Wellness Watch. Trusted information for us, by us. Dr. Mike Lenore and other experts from around the country and around the world have the latest on how you and your family can get healthy and stay well. It's time for the African American Wellness Watch. Welcome to the Wellness Watch. I'm your moderator, George Strait. COPD, or chronic obstructive pulmonary disease, it can literally take your breath away. Not surprisingly, African Americans are disproportionately affected. Untreated, COPD can kill you, but it doesn't have to. So what is COPD? How do you get it? What can we do about it? And what can we do to prevent it? Well, we have the experts with the answers. The host of the Wellness Watch, Dr. Mike Lenore, who's also an expert in lung diseases, Dr. Esteban Bechard, a professor of pulmonary medicine and pharmacy at the University of California at San Francisco. He's also an expert in the link between genetic ancestry and lung function in African Americans and Latinos. And Dr. Courtney Krim, a clinical associate professor of medicine in pulmonary and critical care at the University of North Carolina at Chapel Hill. He's also medical director at the COPD Foundation. I'd like to welcome you all. So let's start with the basics. Dr. Krim, without getting too technical, what is COPD? What are the signs and symptoms, and what causes it? I bet it's not just one thing.
So COPD, although it has that name, as you mentioned, chronic obstructive pulmonary disease, in actuality, it is, if you will, a combination of two different processes that can occur in the lungs. We call these chronic bronchitis as well as emphysema. And these can be looked at as two extremes of a spectrum in which you have chronic bronchitis, which is basically manifest as chronic sputum production, in which a person produces sputum on most days for a finite period of time over several years. And then you have emphysema, which is a destruction of the air of the lung tissue itself. And again, since it lies on a spectrum, different patients can have different degrees of each.
COPD is a slow burning, insidious disease that comes on very gradually, and it often begins with shortness of breath, a morning cough, when after a good night's sleep, we're recumbent, and a lot of the secretions that Dr. Krim was alluding to, they pool up, and so patients wake up with the morning cough, and the shortness of breath will limit a person's exercise capability, and that just makes things worse. So again, what I tell all my patients is to quit smoking.
Dr. Lenore, how is COPD different from bronchitis or asthma or other lung diseases that you see in your practice?
Well, I think the difference is explained in the description of the disease. Chronic obstructive lung disease suggests that it's chronic, it's long-term. It's not easy to treat over a short period of time. It can be managed, but might not go away. With bronchitis, which is an infection, usually with antibiotics and other forms of physical therapy in the lung, that goes away. And with asthma, with proper bronchodilator treatments, you can clear that. But with chronic obstructive lung disease, it's there for a very long time.
Now, Dr. Bechard, is COPD underdiagnosed or often misdiagnosed, especially in African American and Latino communities?
Yes, it is. And it often requires a specialist who is trained in pulmonary medicine to make the diagnosis. And we do that through a clinical evaluation, which means you just see a physician and he or she can make a presumptive diagnosis, or we do it through what we call spirometry, where we have you breathe in and out of a machine. The travesty is a lot of our community members are low income and don't have access to specialty physicians. And so they're generally seen by a primary care physician or a generalist who may not have the specialized training. And so just by that fact alone, we see a lot of underdiagnosis. There are a lot of reasons for developing COPD. In the United States, smoking is the number one cause, but there are a lot of occupational reasons. The number one cause around the world is due to wood burning smoke, and it's found amongst women. There are a lot of different types of, I'm going to say, flavors of COPD. So there are people that smoke very little and get advanced COPD, and there are people that smoke a lot and don't get COPD. There are people that develop COPD before the age of 50, which is unheard of. The women tend to have a higher risk of developing COPD. And then with vaping, that is a whole new game. We have a lot of research on the direct impact of tobacco smoke, but less research on the impact of vaping on COPD.
Dr. Bouchard, let me stay with you just for a second. There's some lung diseases that seem to have a predilection for African Americans.
Yes.
Sarcoidosis is one that comes to mind. What is that? And I think I read somewhere that the comedian Bernie Mac had it.
Yes, Bernie Mac unfortunately died of it. It's a granulomatous disease, and it looks like, smells like, acts like tuberculosis, but it's not tuberculosis. There is a predilection for African Americans, and that hasn't been thoroughly studied. It is more common in African Americans. It affects all parts of the body, so not just the lungs. It affects the brains, the eyes, all parts. And it's what we call a granulomatous disease. Now, getting back to your other question, are there diseases that impact African Americans more? Well, I was, in addition to being a physician and a pulmonary physician, I run the clinical pharmacology program. And one of the things that we did is we looked at how different racial groups metabolize nicotine, cotinine, and all the byproducts associated with nicotine. And we took 4 groups: African Americans, whites, Asians, and Mexicans, and we infused cotinine. So we gave them the same dose of cotinine in different patients. And what we found was very, very striking. African Americans, for the same dose, the drug got exposed to more parts of the body, or more compartments in the body. So what we call larger volume of distribution. And then it stuck around in the body for longer, meaning that the tissues were exposed to the same dose for longer. And what it tells us is that African Americans were metabolizing cotinine, which is a byproduct of nicotine, differently than whites. And that parlays into a very curious observation. African Americans smoke about 1/10 the amount the whites smoke, but their COPD rates are much higher than that of whites. Now, African Americans smoke a different flavor. They tend to smoke mentholated cigarettes. That's 90% smoke mentholated cigarettes, whereas 90% of whites smoke unmentholated cigarettes. And that gets into a whole can of worms of ethnic specific marketing and targeting markets.
Right.
But to answer your question, yes, there are biologic differences that have biologic consequences and outcomes.
So it seems like, and when I watch television, there are various drugs that are advertised to treat COPD. So I guess that there are treatments out there.
Yes. Again, we have 2 different types of bronchodilators, as well as inhaled corticosteroids. And again, as you mentioned, the various commercials that you will see on television will talk about having either 2 medicines or 3 medicines and one in device that we'll use to treat patients with COPD. The more severe their disease is, the more inhaled medications we will give them. So a person who has relatively milder degrees of COPD, we may use just one medication. As they have more symptoms or more shortness of breath or more events that take them to an emergency room or become hospitalized with their COPD, we may use 2 or 3 inhaled medications. So the medications will be given based on the severity of their disease process.
So, Dr. Bouchard, people don't all of a sudden get COPD. They have other lung issues beforehand. So what should someone do to, frankly, avoid getting COPD?
Well, the number one cause in the United States is smoking. So if you stop smoking, you won't develop COPD. There are occupational reasons that people get COPD, and but those are much smaller. Outside the United States, the number one cause is wood burning smoke. So women that are cooking.
So what about vaping and smoking marijuana?
So let me separate those, because vaping tobacco is different than vaping marijuana. The general rule is the volume of smoking marijuana compared to cigarette smoking is not even comparable, meaning someone might have 1 joint, whereas they might have 20 cigarettes or a pack, 2 packs, 3 packs a day. So we're talking about a log-fold difference in volume. And then vaping marijuana compared to vaping tobacco is it's a different beast. If you're vaping tobacco, it is a precursor. It's a doorway into getting hooked on tobacco. And I think I can speak for most pulmonary physicians. We are not supportive of it.
So,
And just to amplify what Dr. Bouchard indicated, recently, vaping has been related or had been related to inhalation of other substances, which, have led to, a totally different type of disease unrelated to COPD. Sort of like the type of lung disease patients were getting with COVID, in terms of, just truly involvement of all lungs, the lung tissue itself, as opposed to the airway. So, and there had been deaths associated with vaping. So in addition to the issues that Dr. Bouchard mentioned is related to vaping, from the standpoint of COPD, vaping, had been associated with other, deleterious lung conditions as well, which is another reason why people should avoid it at all costs.
So I've got one final question for all of you. How important is it to find a lung specialist that actually looks like us? Dr. Bouchard, I'll start with you.
Well, it's well documented in all aspects of medicine. Racial concordance leads to better health outcomes, whether we're talking about lung disease, heart disease, OB-GYN, physicians, GYNs. That is critical. And for OB-GYNs, whether it's a physician, nurse's assistants, a doula, those are all been proven time and time again to be beneficial. The same is true for surgeries. And damn it, it's published, and I'm mad about it, because folks with diabetes that are African American are more likely to have an amputation than they are compared to their white counterparts, who are likely to have revascularization, which is a less invasive procedure. So we know that race and medicine play a big role, and we just have a shortage of minority physicians. And recent work published in the New England Journal in the last 2 years has looked at this over the last 43 years. And the number of African-American male physicians in the United States has actually gone down in the last 43 years. So we got a lot of work to do.
Cultural aspects of it is important from the standpoint of how African-American physicians understand how the African-American culture plays in terms of how African-Americans view healthcare, how they get their healthcare, how receptive they are to the information they receive, and how it can be presented to them in a fashion that would make sense to them. For example, although we're talking about COPD, we recognize as African American physicians how, for example, if you're talking about lung cancer, how some African Americans, and particularly older African American individuals, may be reluctant to have surgery because they were of this belief that if you have surgery, the air will hit it and that will cause it to spread. Being an African American physician, having grown up in that culture, you are aware that these are certain things that are of importance or of concern to African American patients, and therefore you can explain it in a fashion that can get them to be much more receptive to the advice you give them as it relates to managing their problem.
Indeed, indeed. Doctors Bouchard, Krim, and Lenore, it's information that can actually save lives and really reduce an awful lot of the anxiety around COPD. We've got a lot more about COPD on our website, aawellnessproject.org. That's aawellnessproject, all one word, .org. We also have links to the COPD Foundation's website. They've got a lot of great information there as well. We hope this segment of Wellness Watch has empowered you and your family to take better control of your health. Dr. Lenore, some final thoughts, please.
One of the biggest problems and causes for COPD is smoking. So you have to stop smoking. Even though you have active disease and you've been smoking a long time and you have the changes associated, chronic obstructive lung disease, stop smoking. That's the first thing. Then there are a number of medications that you can take that are specific for chronic obstructive lung disease. They kind of break down some of the barriers between the outside and inside of your lung. They open up the airway. They take care of some of what we call the bronchoconstrictor component of COPD. So there are several medicines that do work for COPD. And finally, there are a number of exercises, lung exercises, breathing exercises, and things that you can do to increase the strength of your lung and to improve your overall physical conditioning. As almost with any other chronic disease, African Americans are disproportionately impacted by this problem. And so it's important to understand that what's causing it and what you can do yourself to avoid it or improve it, and that treatment is available. And so I think this discussion has helped me even to understand better more about the disease and how it's managed. And so as always, I'd like to say thank you for joining those of you who joined us on this program. And remember that health is your biggest asset, so protect it. This program is sponsored through an educational grant from AstraZeneca Pharmaceuticals.